Hello, everyone. I extend my warm greetings to each one of you today. My name is Irkam Shahid Hussain, and I am delighted to be your moderator for this important webinar. As a final year MBBS student at GMDC Karachi, Pakistan, I am honored to stand before you as the representative of the medical community. I also proudly serve as a volunteer for the MHM platform. Our topic of discussion today is preoperative evaluation and patient management, which is a critical aspect of medical practice. We will have the privilege of hearing from an esteemed expert, Dr. Javeria Khaled, who is member of the faculty of the Department of Surgery at Dow University. Dr. Javeria Khaled's expertise and insights will undoubtedly enrich our understanding of this vital subject. But before we delve into the details of our topic, I would like to take a moment to shed light on the remarkable work being done by two organizations that are making a significant impact on our society: the MHM platform and the project IMG. The MHM platform, founded in 2018 and has a noble mission of assisting students in Pakistan. This platform stands as the first and only one of its kind in our country, providing free guidance to MCAT and medical university students on annual basis. To date, the MHM platform has successfully guided over 300,000 students across Pakistan. One noteworthy initiative of the MHM platform over the past year has been the provision of free career counseling sessions to students in various educational institutions, including schools, colleges, and coaching centers. Their dedicated team interacts with the students in ninth, 10th, first year, and second year standards, guiding them towards different fields based on their interest. Their aim is to help the students comprehend the diverse array of available options and empower them to make important informed decisions about the future. Now, let me introduce you to Project IMG, a limited liability company based in the United States. This organization was formed with the purpose of providing US medical education programs and opportunities to international medical students and graduates. Their efforts have resulted in the development of private membership network that connects supports and resources over 35,000 medical students and graduates from 185 plus medical schools in 90 plus countries around the world. Project IMG offers free access to a wide range of medical education programs, including online courses, USMLE exam preparation, didactic lectures, clinical rotations, medical research opportunities, mentorship programs, employment assistance, and more. Today, we are truly honored to have Dr. Javeria Khalid as our distinguished guest. Dr. Javeria Khalid, a member of the faculty of the surgery department at Dow University, has graciously devoted her time to share her expertise with us. We extend our heartfelt thanks to her for her valuable presence. As we embark on this webinar, let us open our minds to the wealth of knowledge that awaits us. Dr. Javeria Khalid will provide us with insights into the intricacies of preoperative evaluation and patient management. I invite you all to actively participate, ask questions in the comment box, and engage in the enlightening session. But switch off your mics and videos so that there would be much less disturbance from your side. So, once again, thank you for joining us today, and let us begin this journey of knowledge and discovery. Yes, Dr. Javeria Khalid, over to you.
Assalamu alaikum. Let's start our presentation. So the topic is pre-operative evaluation and patient management. First of all, what are the objectives of our presentation? I would like to uh, make it clear for all of you. Our objectives are uh, history taking, physical examination, investigations, laboratory and investigations, risk stratifications, perioperative medical optimization, consent, and of course, a take home message. What is pre op evaluation? Basically, it is the evaluation and assessment of the patient in the surgical ward before the day of operation. The ultimate goal of pre-operative medical assessment are to reduce the patient's surgical and anesthetic perioperative morbidity and mortality, to return him to desirable functioning as quickly as possible. It is imperative to realize that perioperative risk is multifactorial and a function of the preoperative medical condition of the patient, the invasiveness of the surgical procedure, type of anesthetic administered. Like, we have to explain patient what type of anesthesia he would be given, what type of what kind of medications he would take after surgery, what pre-op management's plan are here to make him accommodate for the surgery. It involves multidisciplinary teams like surgeon, anesthetic, hematologist, radiologist, and nursing staff. Next. History taking is the crucial of all the pre-op assessment. History is the most important component of the pre-operative evaluation. History should include a past and current medical history, like patient has any comorbs, diabetes, hypertension, any endocrine disorder, or any other urological disorders like he is taking tamsulosin. Surgical history is very important. If the patient has previous any surgical history, he should have many additions in his abdomen or any other part of the body. Family history is important. Social history, like he is using tobacco, consuming alcohol, illegal drugs. These all are very important. History of allergies is important. Current and recent drug therapy, unusual reactions or responses to drugs, and any problems or complications associated with previous anesthetics. A family history of adverse reaction is also important, with anesthesia, uh, which has to be obtained. The history should include a complete review of systems to look for undiagnosed disease or inadequately controlled chronic diseases. Diseases of cardiovascular and respiratory systems are the most relevant in respect of fitness for anesthesia and surgery. Now comes to the physical examination. It is mandatory that a patient is come into the surgical ward for pre-op assessment. So we have to examine the patient. Unexpected abnormal findings on the physical examination should be investigated before elective surgery. It includes vital monitoring, BP, heart rate, temperature, respiratory rate, general physical examination, which gives us clues about anemia, jaundice, cyanosis, clubbing, any other chronic disease which is running in the patient, but we are unaware of that. Respiratory examination, because if our lungs are not clear, anesthesia could not be administered. CVS examination, patient has good circulation or not. So it's also important CVS examination. Abdominal examination, because if we are going for the abdominal surgery, we have to look for the abdomen. Virgin abdomen is a good abdomen for the surgery, but if patient has previous surgery, so it's bit difficult to redo surgery of other causes. And the relevant examination like hernia, perineal problems. Now comes to the investigations. For pre-op patient, if he is coming for the surgery, what investigations are basic or baselines for the surgery? These are complete blood count, which gives us clue about the hemoglobin of the patient. TLC count, TLC count shows us active infection or not, and the platelet counts also. UC shows us urea red electrolytes, which gives us body's basic electrolyte imbalances. PTA, PTT, INR, which gives clue about the clotting factors are working good or not. Viral markers is important because we have to prepare the OT according to that. FBS is important in diabetic patients. LFTs is relevant if we are going for the major surgery like exploratory laparotomy or any other detailed surgery. So LFTs is very important, and it has importance in laparoscopic cholecystectomies or any other liver related surgeries. Chest x-ray is important, as I already gave you about the reasoning of chest x-ray, ECG, electrocardiography. These are the important baseline investigations. Now, perioperative risk assessment. You are a trainee in the ward, and a patient is come to you for the surgery. What perioperative risk assessment tools are there to help you that patient is fit for surgery or not? So, perioperative risk is a function of perioperative medical condition of the patient, invasiveness of the surgical procedure, and the type of anesthetic administered. AAC grading system was introduced originally as a simple description of the physical state of a patient. It is extremely useful and should apply to all the patients who present for surgery. Increasing physical status is associated with increasing mortality. Emergency surgery increases risk dramatically, especially in patients in AAC class 4 and 5. We have PTA, categories of perioperative risk assessment. We have different classes. There is MET class, AAC class, and the CVA classes. But we are using AAC class, which is basic and important, and apply to all the patients. AAC class 1 includes patients which has no organic, physiologic, biochemical, or psychiatric disturbances. AC class 2 include mild to moderate systemic disturbance that may or may not be related to the reason for surgery. Okay, like heart disease that only slightly limits physical activity, essential hypertension, diabetes mellitus, anemia, extremes of age, morbid obesity, chronic bronchitis. These are AC class 2. These are also mild to moderate risk for the surgery. AC class 3 includes severe systemic disturbance that may or may not be related to the reason for surgery. Example, poor controlled essential hypertension. Diabetes mellitus including vascular complications like DVT or you have diabetic foot, gangrenous foot, chronic pulmonary disease that limits activity, angina pectoris. Class 4 and 5 includes emergency surgeries, basically. Class 4 severe systemic disturbance that is life threatening with or without surgery, which includes congestive heart failure, persistent angina, and hepatic dysfunction. Class 5 is moribund patient who has little chance of survival but is submitted to surgery as a last resort. Example, uncontrolled hemorrhage, trauma ruptured abdominal aneurysm, cerebral trauma, pulmonary embolus. And class 6 is a declared brain dead person, which are removed for donor purposes. And E is added to the status number to designate an emergency operation. So these are the ASA class which I'm using for the status of the patient that categorizes it in mild, moderate, and high risk surgeries. Now, patient optimization. Patient optimization includes basically medical adjustments, nutritional support, smoking cessation, alcohol cessation, or any other kind of activity which is not good for the surgery. We have to adjust these things before surgeries. Mm, Now, preoperative medical optimization includes what? We have to adjust the drugs which are necessary to be in adequate doses for the surgery, and some drugs have to be stopped before surgery. Generally, administration of the most drugs should be continued up to and including the morning of surgeries, although some adjustment dosage may be required. Example, antihypertensives, insulin. Some drugs should be discontinued preoperatively. The monoamine oxidase inhibitors should be withdrawn 2 to 3 weeks before surgery because of the risk of interaction with drugs used during anesthesia. There are some drugs which have drug-drug interaction and pharmacokinetic effects which are comparatively increasing or decreasing the doses of other drugs. So we have to be optimized the dosage of the drugs before surgery. The oral contraceptive pills should be discontinued at least 6 weeks before elective surgery because of the increased risk of venous thrombosis. There are some patients which are using herbal supplements which are not recommended in our surgical practice, but they are using it. So herbal supplements, if taken by the patient at least 2 weeks prior to the surgery, should be stopped. Aspirin should be discontinued 7 to 10 days before surgery to avoid excessive bleeding, and thienopyridines should be stopped for 2 weeks before surgery. Selective cyclooxygenase inhibitors do not potentiate bleeding and may be continued until surgery. Oral anticoagulants should be stopped 4 to 5 days before surgery and allowing INR to reach a level of 1.5 prior to surgery. But if there is a patient which is necessary for him or her to take SCART, there are ischemic heart disease patients. So we are decreasing the dose of uh, drugs. Like we are using SCART 75 mg for these kinds of patients, and we are stopping these drugs 3 days before surgery. So there is somehow management of the patients which vary from patient to patient. Next, okay, diabetes optimization. Patient with diet controlled diabetes require no special pre-op management, but if he is on insulin or any oral hypoglycemic drugs, then management is required. Patient on oral hypoglycemic or subcutaneous insulin should stop therapy before surgery and switch to sliding scale of insulin regular. Patients with diabetes should be placed first on lid for surgery because they have a chance to go in hypoglycemia intraoperatively. We have a patient, I remember, that we don't skip his morning dose of insulin, and we went for the surgery. Then during surgery, she goes into hypoglycemia. We stopped the surgery, giving her 5% dextrose water, 25% dextrose ampules. Then we start our surgery again after optimization of the sugar. So it is very important to give her morning, omit the morning dose of insulin. Okay, next. Now, antibiotic prophylaxis. Antibiotic prophylaxis is very important for the surgical patients because there is high chances of surgical site infections in surgical patients, of course. So antibiotic prophylaxis is very necessary. Prophylactic antibiotics should be administered 1 hour prior to surgery or before giving incision to the type of surgery. Depends upon the type of surgery, antibiotics varies. Okay, if there is open surgery like hernia or any wound infected, so we would replace it kind of antibiotics like augmentin or ceftriaxone. And if there is many deep surgical malignancies or something else, so we depends on the cultures. Basically the cultures are helpful in antibiotic prophylaxis also. Prophylactic antibiotics should be discontinued 24 hours after surgery, and in major surgeries like cardiovascular surgeries, we stop antibiotics after 48 hours. Next slide, please. Now, consent has very important, because if the patient is not giving consent, you cannot proceed for the surgery. We basically give consent which is informed consent. Consent should be informed consent. Informed consent is critical ethical and legal requirement. Elements of informed consent are risk, benefits, alternatives. All should be clearly taught to the patient. What kind of surgery is this? What kind of anesthesia should be given? Each and everything should be clear to the patient before taking consent. And after that, we can proceed for the surgery. Consent should be signed by a patient himself or herself unless any valid cause to sign the consent by other family members. Next, conclusion. Preoperative management is essential to prevent post-op complications. Post-op complications and deaths occur in high-risk patients. Multidisciplinary successful management. These are three key learned in this presentation. Last but not the least, each and every detail is important for the patient and the surgery which has to be done. And before going to the surgery, there are some points which I have to add in this presentation, that for any kind of patient which is going for the surgery, you have to make some points like you have to maintain IV of the patient, start fluids during NPO. NPO should be for 6 to 8 hours before any surgery. You have to remove all the accessories of the patient like jewelry or any other accessories of the patient, any kind of dentures, etc. And you have to inform anesthesia prior to surgery. Patient should come after full assessment and evaluation. There is benefit for the surgery, and patient's benefit is that he will easily recover after surgery. So this is a short but informative presentation for all of you. Any questions?
Dr. Javeria, we have three basic questions from the audiences. Number one is that
Okay.
if patient is on warfarin, what should be the clinical approach for the patient who is underwent to the full general surgery?
Okay, for the warfarin patient, we switch warfarin into low molecular weight heparin. There are low molecular weight heparin injections and medications which are for warfarin kind of patients. Next question.
All right, Jeet. So the next question is, what are the guidelines about metformin in the diabetic mellitus patients?
Metformin is not given because I have already mentioned in the slides that hypoglycemics have chances that patient can go into hypoglycemia during surgery. So we have to switch all hypoglycemics into regular insulin.
All right. And what are the complications if patient is using metformin?
Patient will go into hypoglycemia, and after that, low low chances, but there is chance of surgical site infections also. Healing will be delayed, and so on.
Okay, so the last question of today's session is, what should be the approach to the patient with severe psychiatric illness?
Okay. First of all, you have to be with a psychiatric resident or doctor and take them guidance how to approach this kind of patients. And if there is no availability, you should be kind enough to the patient, be friendly with him. After dragging all the history points, you have to be clear enough and ask her family that these kinds of medications have to be stopped or given to the patients.
All right, G. If any of the participants have any other questions, please raise your hands and write your question in the comment box.
Any questions?
Mm, let me check. What are the reasons to stop monoamine? I guess.
Okay.
Yes. Second guess.
Monoamine oxidase inhibitors has some relation with the acetylcholine receptors, which is very important receptor in our body, right? It controls our sympathetic and parasympathetic activities. So if we don't stop these kinds of drugs, there could be a problem during surgery and after surgery as well.
All right, G. Any other questions from the participant side? Yes, Hussain Mohammed, you raised a hand. Please ask your question. What complications due to ये तो हो गया. Um, First question was, what are the reasons to stop monoamine oxidase inhibitors? Second question is, what complications due to monoamine oxidase inhibitors?
Uh, Patients which uses these kind of psychiatric drugs have effect in their mental and also in their body receptors. Okay, so after surgery, when you have to extubate the patient, there is difficulty in extubation. Okay, so the receptors of the larynx and the lungs, they are slowed down, so extubation could be difficult, and patient may land into the ventilators and ICU.
All right. Dr. Javeria, this is a question from my side, especially.
Okay.
Basically, I want to know that there is a bridging therapy when the patient is on warfarin. We usually give bridging therapy by replacing warfarin with either
Low
through low
molecular weight
molecular
heparin.
weight heparin or unfractionated heparin. So, what are the indications for that specifically?
These indications are for patients which has two vessel or three vessel disease,
Okay.
ischemic heart disease patient, or patient having pulmonary embolism. So these kinds of patients which we can't stop warfarin, so we have to replace warfarin with some low dosage of drugs. So we use low molecular weight heparin.
All right. Okay, guys, any other
And
questions? Mm, I don't find any. Yes, Hussein, please ask. Does smoking has any effect on surgery?
yes, of course. We have to stop smoking 1 month prior to surgery, because if patient is on smoking and if he is a chronic smoker, then his lungs has some fibrotic changes, atelectatic changes. So the general anesthesia may be difficult. So smoking has very much effect on anesthesia intubation. Not on the surgical side, as during surgery we have chances of deep venous thrombosis and which is related to the smoking, but more difficulty will be in intubation.
All right. Dr. Javeria, is there any difference in between a normal bronchodilator and the theophylline, which is a special bronchodilator which is used for COPD patients? So, is there any indications or any difference in between the two, either to continue or to stop for the surgery?
We have to continue theophylline, but not other bronchodilators, or otherwise we just give patients salbutamol bronchodilator and nabs with it. So we use small, we use basic bronchodilators, not on high doses.
Okay. All right. We have other question. Which drug is most preferred to be continued in diabetes mellitus type 2 after patient is post-op?
After post-op, all drugs which was taken by the patient prior to the surgery is continued same.
Um,
We
he's
have
saying.
switched them onto regular prior surgery. Yes.
All right. So, Dr. Javeria, you can ask questions from the audience
Okay,
from
I
now on.
would like to ask them question. Which type of consent is taken during surgery?
Guys, please answer. Dr. Javeria is waiting. Informed and written consent.
Great. And which team is crucial for successful management of the surgical patient? Great, Fatma. Good job.
Multidisciplinary.
Okay, my
Fantastic.
last question. Should we continue antihypertensives on the day of surgery?
No. Yes, with um, Hussein Mohammed say no. Bilal Ahmed says yes with a sip of water. Rimshia says no. Ishna says yes. Wadia says no. Lalan says no clearly.
It's a yes, of course. But as I said previously, that as card and these we have to stop them. But other antihypertensives like atenolol or angiotensin receptor blockers, we can continue them with a sip of water, as said by the Bilal.
Okay. Dr. Javeria, is there any sort of clear guidelines related to hypertension uh, that these patients should go into the surgery or not due to hypertension? Are there any
Uh,
specific guidelines?
there are guidelines, but I don't remember the exact name of the guidelines. But there are present guidelines, which will I give you in the next session.
All right. So, okay, guys, thank you for your cooperation. Um, Due to limited time frame, um, we have limited questions that Dr. Javeria has already been asked, and she's also ask question from her side, and the answer was given. So please feel free to email us if you need more help. Also, there will be more webinars in the future where you can ask your questions if we don't get to them this time. You can contact us through email or our website. Thank you very much for your cooperation and for your time.
Thank you so much.